Hey, welcome back everybody. We got another Couch Talk session where we get to review how I spent my Tuesday, which is my day as CCO, where I go around and do some mentoring, coach reading, and really just overall staff development at our different locations. This past Tuesday, I was at our Frederick location, and while I was there, I got to spend time with 3 different PTs. I got to spend time with one of them who is onboarding their first DPT student. And then I got to spend the next part of the day with one of our newer clinicians around that 3 to 4 month mark with the company. And then I got to spend time with one of our residents. So get to bounce around a little bit. When I was with one of my residents, the case that he had was an individual coming in for a knee injury. They had an injury on the playing field, went to the orthopedic, got imaging done. No big red flags, no fractures, nothing torn, but they were having some discomfort. They were having some issues with ambulation. Dad had mentioned that their kid was walking funny, but to complicate things, he's kind of always had an abnormal gait because of an old ankle injury in the past. So they're really coming in for PT to figure out, what do we need to do? We went to the orthopedic, we figured out there was no fracture. We figured out there was no ligamentous or cartilage damage, but we're obviously not 100%. So how do we move forward from here? Is it as tolerated? Do we need to go through a formal PT routine? What does the end and the discharge look like for that? And these are honestly some of my funnest cases because you get to have a lot of independence and a lot of autonomy with the plan of care. You've been kind of given the green light from the referring physician of, hey, there's nothing sinister, nothing suspicious that you need to worry about. Proceed logically, kind of proceed with caution, but you can go on an as tolerated basis. And then the return to sport and return to activity decision really comes down to what is the individual symptom profile? What is their movement profile? Meaning, are they moving consistently with their pre-injury status and in a manner that's going to set them up for success and safety when they return to the field? And then what is their overall confidence with doing all this? Now, the last piece of the puzzle that I think a lot of people tend to overlook or take for granted a little bit is just the fact that we have had a little bit of time loss from this injury. So the last thing that we want to do is be in a fully competitive state, practicing regularly on a weekly basis, playing competitively in games and matches on a weekly basis. Then we have this traumatic injury. Following the traumatic injury, we have a series of 1 to 2 weeks where we're not really doing much of anything at all. We are feeling better from a symptom standpoint. We're walking better, range of motion's coming back, swelling's going down. We're starting to do a lot of our just daily activities pain-free, but we haven't done anything at really a high intensity or even a moderate intensity. So that's where you got to start to navigate that return to play process. What's our practice participation looks like? What does our participation in a game or a competitive match look like? And there's not a perfect recipe that you can follow for that. A lot of that has to come down to truly understanding what it is they're trying to get back to. What's the sport that they play? What is the number of minutes that they're going to be playing or the number of plays that they're going to be when they're in that sport? Are they a starter? Are they somebody that comes in off the bench and they get kind of intermittent throughout the games? What's their overall workload look like? Not only what does their workload look like within a game or a specific session, but over the course of a week and a season as well. And that's where we can start to figure out, all right, how do we look at these chronic workloads or these acute to chronic workload ratios and just make sure that we're doing this in a logical manner where we don't ramp them up 0 to 60 over the course of a night. So speaking with our resident, he really knocked the eval out of the park in regards to things that he was looking at, defining function. With this individual, the kid's actually pretty functional at this point. Symptom profile has gone down, ambulating pretty normally, a little bit of gait abnormalities, but kind of ties back to what Dad was saying of, hey, we have an old injury and an old issue that we've been dealing with that's kind of always been involved. This is an area of opportunity where I think you can intervene and try to clean up and tie up some of those loose ends as you're working on the current injury at play as well, because they're going to directly relate to one another. An old ankle injury, a current knee injury, they're going to go hand in hand. The other thing that we need to appreciate with this person is just what is their current functional status. So doing some of the Tyndek, the isometric testing of knee function, doing anterior step downs, we were able to get some good measurements as to what does this person look like on a left versus right basis, and just a normative data standpoint as well. And then ultimately just doing an informal movement assessment. How well can this person hop? How well can this person jog? If we're getting them on the turf, how comfortable do they look doing some basic foundational locomotive patterns that I think the large majority of the population at that given age should be able to do? But then what do they look like when they start doing sport-specific activities as well? And the spot that we're at with this individual now is they're checking a lot of those boxes. So we don't need to do a significant amount of time in regards to restoring strength, restoring overall movement patterns. But what we do need to spend time doing is instilling confidence with some of these movement patterns following an injury, exposing the knee and the lower extremity to the different environments and the different movements and stresses that it'll encounter in the upcoming competitive practices and games. And then also just starting to build up a workload and a volume again. And I think that's one part in the PT field where we fail to capitalize, is using those couple weeks after they've restored all of their impairments that we learn about in PT school, how to identify them, how to intervene on them. But then we need to bridge that gap back to competition. And I think an often underutilized part of the PT aspect, and when you work in a facility that has the resources to do so, I think you should really be focusing on it, is building up that exercise intensity and volume to get them back to what their previous level was. So there's not such a disconnect between injury work volume, competitive work volume, and we're having a more linear return as opposed to a rapid spike. So that was a fun case to look at with the resident. Really kind of encapsulates what the sports residency is. We also had the component of him needing to educate and communicate with the parents. So not only the patient who is a youth, but also the parents. So you get kind of teased on the X's and O's of PT, but then also the communication and just interpersonal multidisciplinary approach as well. So fun case to review. Hopefully you get something out of that.